the next case, the T3 and the T4 levels are in the normal range and TSH is on a lower side, less than 0.1. So the diagnosis here can be again probably we dealt with subclinical query, subclinical hypothyroidism. Now here only scenario what has changed is probably it can be subclinical hyperthyroid, or the other things may still remain the same. Free T4 may help us to further conclude. Again the free T4 is in the normal range. I think here it will be similar.
Yeah.
If clinically there is nothing, there will be no treatment initiated?
Yes, for adult patients, no treatment. For elderly patients, treatment. Because their chances of atrial fibrillation, osteoporosis go up much higher.
Right.
So it's recommended that these patients be treated, but young adults need not be treated.
T3, T4 are normal, but TSH is markedly elevated. It is not in the subclinical or borderline range. So, any probabilities? On therapy? At normal adult.
Is it peripheral resistance?
So, we thought of two differentials here, either TSH receptor antibodies which may be there, or presence of thyroid hormone resistance. So, this would definitely require a further evaluation, clinical correlation as well as maybe further testing. Free T3, free T4 levels were also normal. Antibodies were negative, the routine ones, the anti-microsomal as well as the anti-thyroglobulin antibodies. So, then we advised TSH receptor antibodies which were positive in this patient. Sir, if some patient comes with you with this kind of a report to you, what would be your next line of action?
Reaction, I would not react, because see, whatever you have, if you have done your test properly, it is my headache now to sit and figure out what it is, not to pass that headache to you. So I would only react saying I don't know what this is and I need to find out. But this thyroid hormone resistance, I don't necessarily agree very much. First of all, thyroid hormone resistance is very, yes sir, but see, the problem is that receptor antibodies, as I said, can be found in large number of people who have thyroid disease. So as I said, most people will have autoimmune thyroid disease. So finding an antibody in them, it will not help you resolve the issue. You know that it is going to be there, probably.
Right.
The problem is, we have some patients where the first thing that will come to my mind actually is that this patient is malabsorbing thyroxine, because the TSH is not coming under control. That's one possibility. Therefore, this patient's thyroxine dose might have to be pushed up. The second thing is that patients who have congenital hypothyroidism, sometimes the TSH osmostat, let's call it, is completely reset. Therefore, TSH may persist to be high even in adult life, despite being normal in T3, T4 and FT4, and they are clinically also euthyroid. So that's another possibility. When you say thyroid hormone resistance, now here you are saying what kind of resistance are you talking of? Is this peripheral resistance?
Yeah, peripheral resistance.
It will be again, no, the pituitary resistance as well as the peripheral resistance, because if the pituitary is not sensitive to the normal T3, T4 levels, then also it will probably keep on secreting the TSH.
In that scenario, you would have a very high T3 and very high T4 as well. So this is not a typical case of thyroid hormone resistance.
Right.
If you had peripheral plus pituitary resistance, you would find very
T3,
high
T4 also
T3,
high.
very high T4, very high TSH, and patient clinically grossly hypothyroid.
Right.
So that's a very rare scenario.
Yeah.
It's hardly ever seen. Then you're talking of an isolated pituitary resistance, which I don't know. These are very uncommon
Very rare,
cases.
very uncommon.
But TSH receptor antibody positivity. No, I agree.
Yeah.
I agree with you. So I don't know.
TSH is repeat
treated
Yes.
and we got the higher value.
As I said,
Then
once
we-
you have done the test properly, then I have to sit and figure out what this patient has. These are things which come to my mind. Either he's been missing intermittent therapy or he's not absorbing thyroxine. That would still be my first diagnosis.
But if he is not absorbing thyroxine, then still his T3, T4 and free
That's
T3,
okay.
T4 can be normal.
See, there are some patients who, in my practice also, I have a collection of them now, who require almost 800 micrograms of thyroxine to keep their thyroid levels normal, very uncommonly. There are a lot of theories about this, we'll not go into that, but basically some of them have celiac sprue, some of them have Helicobacter pylori infection, so on and so forth. But there you can have such reports. So my first thing which comes to my mind is that this patient is hypothyroid and is not taking therapy.
But the textbooks mention a concept called as non-functioning pituitary adenomas, which may have a little higher values of TSH with normal T3, T4, because they secrete certain non-functional TSH which are picked up by these assays.
Yes.
But they all say that it
It's
may not
too
be
high.
this high.
This
it
is
is
too high.
very in the subclinical ranges, not even
This
above
is too
10.
high.
Right.
So as I said, my first diagnosis would still be that.
Right. In this case, the TSH is elevated, and because we also knew it was a part of ANC profile that the patient had got the thyroid function test done. So it was a female patient, and first trimester pregnancy was there. So would you now consider this as
I said in my speech also, that nowadays anything which is abnormal in pregnancy, there is a tendency to treat because number of studies have shown some better outcomes. The evidence is not really very strong, but currently I think I would treat whether antibodies are positive,
present.
negative, whether FT4 is normal, low, high, whatever. If the TSH is 5.76, I would treat.
okay. The next case is the opposite of what we saw earlier. Again, first trimester pregnant lady, normal T3, T4 and low TSH values. But low values are seen in pregnancy. So in this
Yes,
case,
this is typical HCG effect, and I would completely leave this alone.
so it will not be treated. No,
100% not. This would be just followed up.
but in case the antibodies are positive in such a
No,
scenario,
I would not
still-
treat.